that part. Both campus and advance and the Advance Award were initiatives from this UC Davis Advance program. It was an NSF-funded program that was active between 2012 and 2018, an institutional transformation grant that was then absorbed by UC Davis. It was institutionalized, and well, here we are. We continue thriving as a center. We have 39 faculty, and we have been giving this award since 2014. There's been 17 different awardees, and the Advance Award honors Academic Senate and Academic Federation faculty who advance diverse perspectives and gender equity in STEM through their research, teaching, mentoring, and service. So it is a research award. People for this award need to be excellent researchers, and then on top of that, they need to be advancing these multicultural perspectives, like having contributions to teaching, mentorship, and outreach or service to the profession, to the community, to the university. So they're the best of the best. Today's symposium honors one 2021 awardee, Jesus de Loera, and two 2023 awardees, Miriam Nuño and Dean Tantillo. Each one of them will give a plenary style lecture. We have built in a lot of time for discussion among the participants, so you'll see that there's a talk and then a big break and then another talk and then a big break. We'll have a poster session where we can hear about other people's work and lots of, well, some students and postdocs. And we will end the day with a panel discussion. There will be food provided throughout the day, so I hope you enjoy spending the day with us. The sponsors for the event are the Office of Diversity, Equity, and Inclusion with campus and the Office of Academic Diversity, the NSF-funded UC Davis Tetrapods Institute of Data Science, UCD for IDS. Those are the main sponsors. And with that, I will pass the mic to Luis Carvajal Carmona, Associate Vice Chancellor of Academic Diversity and Professor of Biochemistry and Molecular Medicine, and Auburn Endowed Chair in Basic Cancer Research. It's early.
Okay.
Thank you.
I have this one. Thank you, Mariel. Thank you, Mariel. And I'm Luis Carvajal Carmona. I'm the Associate Vice Chancellor for Academic Diversity. So we are part of the DEI office here on campus. And in the Office of Academic Diversity, we have 3 programs. Campus, the program that is organizing this event, CAMSA, which is diversity in the social sciences, humanities, and arts, and the Hispanic Serving Institution, the HSI initiative. So we have a new office on campus, and we are all about inclusive excellence. And this symposium is about that. We have a lot of talented faculty and members of the Academic Federation who are very talented, and we want to celebrate and highlight their contributions. Teaching, mentoring, research. Okay, so we are going to be listening to 3 outstanding academic researchers, scientists from the institution that have contributed to Advanced Campus Mission. I am one of the awardees. I was lucky to be awarded the Advance Award last year, and it's very important for us. Okay, and campus is, I will say, or the Advance Award is, I will say, is the only award on campus that recognizing how, the outstanding, excellent, inclusive excellence that we have on campus, okay? We have a lot of awards where, they are about academics, and we rarely see a black and brown faculty, and this is not the case for Advance, okay? And in our Office of Academic Diversity, we want to support and grow the inclusive excellence environment, ecosystem of Davis. So every day we grow more and more our mission to provide opportunities for everyone on campus. So this is a great award. It meant a lot to me, and I'm happy we have 3 outstanding awardees today. The first one of them is Dr. Miriam Nuño, mi amiga. She is Associate Professor in Biostatistics in the School of Medicine. And Dr. Nuño did a postdoc in UCLA. She was an assistant professor of neurosurgery in Cedars Sinai Medical Center in LA. And we have been lucky to have her in the faculty since 2017. Her research focuses on design and analysis of observational studies in the context of public health. And she's a statistician, mathematical epidemiologist, and public health advocate. She's outstanding, right? And I was lucky to have her as one of the colleagues in a project that we had on campus called Orally COVID-19, which was a grant from the National Institute of Health to help control the pandemic, COVID-19 pandemic, in one of the most marginalized communities in this region, which is farm workers. So we were offering free COVID testing to farm workers, similar to Healthy Davis Together, but in the most marginalized communities. So we haven't, in that project, we help over 25,000 families with free testing. And Dr. Nuño was really involved in this. So I remember having this conversation with Dr. Nuño here, and she brought her perspective on analysis, mathematics, and how we could understand what was going on in the pandemic. She helped us secure additional funding. So this is what this advanced hour is all about recognizing these important contributions that have an impact in our community as Davis, but also in the community that we should strive to serve, which all these people around who don't have the privilege that we have in Davis. So with that, I welcome Dr. Nuño as our first advanced awardee. Yes, welcome, Dr. Nuño.
Thank you, Luis.
Okay, yo creo que este es el tuyo.
I got it, thanks. Hear me okay? I don't know why I'm nervous. I've done many talks. So thank you everyone for having me today and giving me the opportunity to share some of the work that I do. Today I will speak about the math of social change, transforming health equity and social justice. Before I talk about my outline, I guess my only disclaimer is that I'm a trained mathematician, applied in statistics, and in the past I've learned about epidemiology and public health and community engaged research, so I'm not an expert in any of those fields, but I have enjoyed playing in the background with the people that do that kind of work. So first, I'll talk a little bit about my role and how I see myself as an ecosystem for social change. I'll talk about a little bit about my collaborations and my collaborators and kind of emphasize on diversity and health equity, which has become much more of the work that I do. I'll feature, I have here 3 projects, but depending on time, we might just talk about 2, but I wanted to give you a flavor of what kind of work we do and why I think social change and equity is at the heart of what we do. And then future directions. I know that this is how we think about technology and transforming health equity, and so I just will share a little bit about my thoughts on that. So in terms of my roles, I mentioned that I'm a trained mathematics and statistics person, but really I have been really privileged to work with people that have different interests, and so a lot of my work has applications in infectious diseases, public health, climate change, health disparities, and I really included this piece at the very bottom, which talks about how the work that we do could be focused on diversity, equity, inclusion, and justice. The justice piece I'm still learning about, but I feel like there is potential to keep moving in that direction. So in terms of how I think myself, in terms of an ecosystem for social change, I was telling my postdocs that when I was putting this slide together, I had to think about who I am and how I feel and fit in the context of research. And so what I have learned is that greater self-awareness really is critical to what I do. Often when I started my career, you're seeing yourself as a minority, so you often think, okay, I have to do what everybody else does. And over time, you realize that what's really unique about you and your contributions is really what makes you special. And so when you come into the pool of working with people in epidemiology, public health, really who we are should be a strength. And so I sort of put together here just 4 sections that talk about my strengths, my roles, the power of being able to appreciate who really you are, because my experiences as an immigrant and everything that contains really kind of speaks to why I'm interested in the work that I do. And then the collaborations, which I feel that it's critical to do work that is not isolated. So you really need to learn to, at least for me, to work with people in different areas. So I feel like this slide here kind of really allow me to say okay, what is it that I do? Why do I do that? What do I work with these people? Why do I get involved in those projects? And I feel that it has been a really self-discovery journey for me. I just want to acknowledge my team. I have been pretty lucky to receive funding from Campus and Healthy Davis Together, and bring on board a diverse group of students. This is just a subset of the ones that we work with, but we have a lot of undergrads and grads that we work with. I included here some of my collaborations, but really this list is much bigger than this. I included here these collaborations, as Luis was mentioning, some of the work that we have been doing with oral COVID testing. We ended up doing a little bit of work on vaccination as well to improve vaccination in the Central Valley. My work with Sergio Aguilar-Gagiola with the Center of Health Disparities has also been sort of a revelation. I'll mention that when I came to Davis, 7 years ago, I knew about Sergio, and I was like, I gotta connect with Sergio because I know he's doing amazing work, but I never felt like what I'm doing is good enough yet to go meet him. And so it's funny that now we're colleagues. So Dr. Martinez, he works, he's a cardiologist, and he works on organ donation, and we're trying to understand how to improve registration for organ donation, especially in the communities that have the greatest demand. And also I have some colleagues here at the bottom, which are the wastewater surveillance colleagues, Colleen and Heather, and then some of the work that I have been doing with Rebecca on wildfire exposure and how that impacts pregnant women in the Central Valley. So I feel like I've been very blessed to work with people that are trying to answer problems, and I tend to sneak myself in there and say, hey, what can I do to contribute to the work that you're doing? So I'll talk about the first project that we got involved with during the COVID pandemic. Back in 2005, when I finished my PhD from Cornell, we studied pandemics back in 2005, and some of the work that we did was actually, simulate how would you protect nursing homes, because since 2005 we knew that if ever we had a pandemic, that nursing homes would be places where we need to focus. And so when the pandemic came, one of my initial reactions was like, we have enough mathematicians doing modeling, they don't need one more. I was just like, trying to think about myself staying away from, doing all that work. But eventually we got involved because no one was talking about the nursing home impact of COVID. So we did this where we're looking at testing and vaccinations to reduce the impact of COVID. And we did an agent-based approach. I think that we all kind of are, really not so excited to hear about COVID, but this slide really just to tell you that, nursing homes were places where there was the greatest deaths in those facilities. Up to 80% of all deaths that we saw in the US were nursing home residents. And so there's definitely a major motivation, and I mentioned that, we did that work back in 2005, and when COVID came and this was a problem, I kind of was thinking to myself, I did this work back in 2005. I got my paper published. I was really happy. But then what came of it? Like a nice publication. And so I feel like these kind of experiences have pushed me to say, well, what is next? What can I do with my work to go connect with nursing homes? How do we give the interventions that we simulated to be effective so that they get implemented? So I feel like some of these experiences have really pushed me to push the needle of what's next. Because often as a mathematician, you're like, my job is just to run the models, get the papers published, and we're happy. But now that's not enough. So this is what we did with the nursing home example. It gave me really an opportunity to think about what kind of models we would needed to do. And so we did an agent-based model, and more than what models we needed, we needed to assume more parameters for these models. So we were thinking and looking around, like, how do we get those parameters, right? And so I called all kinds of nursing homes in California and Montana, everywhere, and I was like, hey, would you be willing to like chat with me and allow me to figure out how is the dynamics of your nursing homes so that we can run a model that is as close to reality as we can. And so we did get one nursing home that was, obviously everyone was overwhelmed and they're like, we don't have time for that. We are trying to keep our residents alive. But we did get one nursing home that I interviewed for almost 2 hours. And based on what they gave me in terms of information, we used that information to assume how to initialize the model, what parameter estimates to use, and so forth. And so I won't go over all the details, but really what the model is that we have nursing home residents, and inside the nursing home, you have residents, staff, and visitors. And we have different epidemiological classes like the susceptible, exposed, infected, those that died, those that were hospitalized, those that were undetected. But really is you assume a population within a nursing home and you give them an epidemiological class. And then you also assume a similar population outside. And then you run the model and you say, okay, what happens? You know, staff come in and out, visitors come in and out, and residents just stay inside. And so what we do with this is we say, okay, let's run some scenarios, right? And based on the different scenarios, what things seem to work. And our goal is, can we prevent the introduction of the virus in this nursing home? And in theory, you should be able to do that, but it's not so simple, obviously. So I'm not going to go over all the details, but we run different scenarios. And really what we wanted to focus on is when we run in the simulations, there was no vaccine yet. So we just said, what kind of non-pharmaceutical interventions can we put in place to protect these residents? And so we looked at different things like, and things that were being done, meaning there was like, using PPEs. There was one huge factor was the working schedules of staff. So if staff work 5 days a week for 8 hours, come in and out, what happens if instead you switch the schedules for 4 hours, 4 days, and longer periods? Is one less day that they're outside. So that was one of the other interventions that we looked at, staffing working schedules, and then visitor restrictions. Now, as we all know, when we're at the peak of the pandemic, restrictions to visitation was 0, like no one can come in and out. But with this model, you can say, okay, what happens if visitors come, once a week, once every 2 weeks? And so the categories that I present here, the baseline is the situation when you don't do anything. Category 1 is when you start incorporating your restrictions. And category 5 is where that is the worst case scenario. No visitation, the most up-to-date testing, the most up-to-date stringent measures to try to prevent the introduction. And I will mention that in this nursing home that I connected with and I interviewed that person, it was very kind of amazing because as you were seeing nursing homes be, really devastated, this one nursing home that we work with, they didn't have a case yet. And they didn't have a case for almost 6 months. And I think one of the critical pieces that the owner was mentioning to me is that they had a lot of empty beds, and they said, I'd rather lose money than bring in a person that gets transferred from the hospital and then gets in, right? And so one of the things about equity and these issues, I was thinking to myself, how many nursing homes can actually afford to do that, right? It really is a matter of resources. So eventually the nursing home did have a case, and they had a small outbreak. But because they had a lot of empty rooms, they could isolate and do really cool stuff and have such a poor outcome. So I'm going to just give you a little bit of, these are the parameter values, and I don't expect you to go through them, but just to know that the parameters that we use were really as close to that we could to reality in terms of the dynamics of these nursing homes. And these are the different scenarios that I mentioned. On the very top left, you have the baseline when you don't do anything, just business as usual. And then if you go to the very right, where we have category 5, this is like the worst case scenario where you put in all the bells and whistles in terms of non-pharmaceutical interventions to try to reduce the risk of exposure and introduction. And so these are the results that we obtained. On the right, on the y and the x-axis, we have R0, which is the basic reproductive number. And the basic reproductive number is the number of infected individuals that an exposed person can generate during their infectious period. So, typically, if R0 is greater than 1, you will have an outbreak. And so we looked at different scenarios for an R0 that was 2, 2.2, 2.4. And I think for the pandemic, what we're seeing is somewhere between 2 and 3. In some cases, maybe higher than 3. But what you really should look at this is on the y-axis, we have the attack rate, and then we have different scenarios, the one in blue, and 50%. So what we were trying to figure out is if the rate of isolation, asymptomatic isolation, increases if we reduce isolation by 10%, which is the black at the bottom, by 90%, this is what you will have in terms of an attack rate. So what this picture told us, that your isolation rate needed to be so high for you to be able to accomplish, a reduction in the attack rate. And I think the conclusion from this slide is that it's almost nearly impossible to prevent the introduction of these viruses. But at least I think that you can figure out that asymptomatic isolation was the key factor that you have to focus on. And then these ones are just looking at, well, since we know that it is very unlikely to prevent the introduction, then on the left we looked at how might you do to reduce the peak of cases. So the two figures on the left give you two different pictures, one when there's 0 isolation and one there's 50% isolation. And so you can see the reductions in peak of cases when you incorporate isolation. And then on the right-hand side is, of course, we know that once the virus gets in, can we delay to when it will peak inside the nursing homes? Because if you can delay to when the peak will happen, it gives you an extra few days to prepare and do something to, be in a better place. And so we saw that, isolation not only can help you reduce the peak of the outbreak, but it buys you time. So, so these are some concluding remarks from that study, that community outbreaks were almost always followed by an outbreak in a facility. So whenever there was a community outbreak, you know for sure that those nursing homes within that county or that setting are likely to observe that. And we saw that even in the most restricted intervention plan, which was category 5, we did not see a large difference in the attack rate until isolation was nearly 80%. So I think, as I said, it's difficult, but I feel that, if your priority is to protect the health and the people in your community, then that's what you have to do. And so, because this is a conference about technology and how do we, use technology in ways to improve equity and so forth, I wanted to just say that, we publish our work, and I still keep thinking every night, like, what am I doing with that work? How is that information going to these nursing homes to change what they do? So I think that one of the things that we hope to think about is how access to real-time data on cases and testing in nursing homes is critical to develop these models, and technology tools like surveillance for mitigating the burden. So, the work that we did, we can actually build it in a way that the nursing homes can use it themselves and monitor their situation. I know oftentimes the hardest thing has been to have them share the data with us. So we're at the point where, like, you don't need to share the data. Here's the tool, here's the dashboard, you use it, implement it. And so I think that thinking about surveillance and how we can help, that would be great. I know that I might not get to talk about the wastewater surveillance projects that we're doing, but there is, wastewater-based epidemiology that which our team has been using. And one of the questions that we're thinking is, can we use wastewater surveillance to think about, how these nursing homes may be at greater risk of outbreaks? Because wastewater-based epidemiology gives you, on average, maybe 5-7 days, sometimes longer days, where you can detect the virus in the wastewater before in the community, before the nursing home. So I think that there's a nice potential way of building that. And one other thing is, I know that COVID is still here, not to the degree that we were worried about before, but for nursing home residents, they are one of the populations that are devastated by regular influenza. So 90% of flu-related deaths are taking place in 60 plus age individuals. And 50 to 7% of flu-related hospitalizations occur also on these older people. And people that live in nursing home facilities are even at greater risk because they have a lot of comorbidities, dementia, so many risk factors. And so with that, how can our work be expanded to, say, monitor flu? Something as simple as flu that for us is not a big deal, for them is a deadly cause. And so I think you can think about cost effectiveness because you can, reduce infections and clearly, the life of people. So how am I doing on time? Good? Okay. Perfect. Okay. So the second project that I want to talk about is we had a project in which we were assessing the impact of COVID-19 vaccinations on California return to normalcy. On June 15, 2021, California said, we're good to go. We have vaccines. We're ready to go back to business as usual. And I do always realize that there is this economic burden that you have to balance, people's health, economy. But one of the questions that we were thinking about is, are we really ready to go there, right? And the main question that we had was that, California was saying we're ready because we have so much vaccine. I think it was like 70% of people are vaccinated, so we're ready to go. And we knew by working with, as Luis was saying, working with Orale and Move It Up and some of these other projects, we know that there were counties that they were 30% vaccinated. So we're like, even though as an average California is okay, there's clearly communities that are not there yet. And so we were like, hold on, let's do something that we can, sort of do a model to think about that. So we implemented a real-time Bayesian data simulation model that Mari and Chris conducted, and we wanted to see, are we really there yet with the vaccination? And so let's go over that. So as I mentioned, on June 15, 2021, California Department of Public Health issued plans and guidance to full, easy, and of all business restrictions contingent on case vaccination and equity measurements that were on track. In this particular study, we addressed the advocacy and the efficiency of vaccine uptake within California and the possibility and severity of a resurgence of COVID as these restrictions were going to be lifted, given the current vaccination rates. And so this is the model that we looked at, again, we started with an epidemiological model where we had susceptible individuals that were exposed, individuals that were detected and not detected for symptoms, individuals that were recovered and dead. And then because people were getting one vaccine or two vaccines and eventually they got a booster, we wanted to see, okay, first doses and second doses. So V1 and V2 are the categories of people that have one vaccine and two vaccines. And in this model, we assume that individuals in all the EPIC classes, with the exception of those diagnosed as positive, were vaccinated. And at that time, always the vaccine was partially affected, suggesting that some individuals that are vaccinated can also be reinfected. And we assume what the data was known at that time, the vaccine efficacy was different, whether you had the first or the second dose. And vaccination rates were estimated using daily data. So as new data was coming in from the CDC, we were making different assumptions on vaccination rates. And so these are just some parameters that you could be aware of that we had. We had things about transmission rates and effective population, the vaccination rates for those people that had one dose versus those with two doses. And then, and these are the references of the, at the bottom, the references of the parameters for those models that we assumed. And then on the top, those 5 parameters were estimated from the data. And And so one of the nice things with this Bayesian sequential forecasting method, which Mari and Chris, they came from Mexico, they were working with the Mexican government and they were using these methodologies. When they came to our team, we soon realized that the kind of models that we were doing, or that a lot of people in the US were doing, are these deterministic models that assume that people have equal contact with different individuals. And as the pandemic had really progressed, those models are ill prepared to handle the updating of your data. And so this was really a great approach that they brought on board, and we have been using it over time. And so the forecasting with this approach is sequentially updated over a sliding window as new data becomes available. So this approach allows you to estimate parameters, and those estimated parameters to be updated as new data comes in, which I think is really a great approach. And so these are the kind of outputs that you can get from these models. On the very left, we have the distribution of beta, which is the transmission rate. And I believe, Marty, was this for Davis? Yes. No, for California? Okay, California, sorry. We did a bunch of Davis, y'all, but this is California. Okay. So, when you look at this, if you look at the figure on the left, when we see, about March 14 is when we had the biggest peak, right? This is where we had the major outbreak. And then you can see that over time, those parameters stay kind of steady, but then, after June 5th, that you kind of reach a new level. And so that's for transmission. On the B, and the figure in the middle, you are estimating the proportion of the effective population. So the effective population is those people still out there that are, still kind of potentially able to fuel the fire in terms of further infections. And then on C, this is the fraction of individuals that were dying from the infection of COVID. And so, one of the nice things that you will see is that these parameters change over time, and so there's really a great approach that allows you to see how the dynamics of that pandemic are evolving, especially as vaccination was changing, as new variants were emerging. So I think it's we're pretty excited. So then for the question that we had is, are we there yet, right? On the very top left, we have the figure that looks at cases, cumulative cases per 100,000 population on the top and the bottom. And what you can see on the top left on A is where we're changing beta, which is the transmission rate. So what happens if transmission goes from 0.4 to 0.5, and what kind of reductions that we expect. And so the dashed line is the point where we say, okay, what happens from now on if we look at different scenarios when the transmission may change. On the bottom is when omega change, and that was for the cases. And then on the right-hand side, we have, again, changing beta and omega, and looking at cases on the left, those two rows, and then deaths on the right. And so this is kind of what we thought. Are we, in a way, ready? And so when June 15 came, this is the population statistics that were provided for California. So California in January 2022 was about 80%. And we say, okay, we hit the vaccination goal of 75%, we're good to go, right? Everybody will look at this and say, okay, at least that many people have, the one dose, at least that many people have full vaccination, which full vaccination was 2 doses at that point. But then what happens when you start looking more deeply, right? If you look more deeply, for instance, on the left, you have Yolo County, on the right, you have Sacramento County, you can clearly see areas in which there were much less than 75% vaccination rates. And on the figure on the right, you have at least 1 dose. On the left, you have fully vaccinated. We included in these figures proportion of Latinos and African Americans in individuals without insurance in those hotspots to see really that when you look deeply, it's not so clear. that we all are 75%, and what does that mean? And so I think for us, we were just, what we were doing at that point, working with Orale and Move It Up, we were saying to these counties, look, this is what you look like. And they will come to us and say, okay, let's go to that county, what's going on over there? Like, people don't want to get vaccinated for these reasons. And then we'll come back next week and say, okay, well, we did this and that, hoping that those rates are increasing. So I think that when California said we're ready, it really is the county's responsibility or those community partners to say, hey, let's go and hustle, because this is not looking good for us, right? And so I think that's kind of the whole point with that. The last project that I will just briefly discuss, I don't want to dim too much, because Mari has her poster. Mari and Chris have been super busy throughout the pandemic and putting themselves on the map, really, on the work that they're doing on wastewater surveillance, and how it's such an untapped resource that it has tremendous potential. And because they're applied mathematicians, they have been pushing really the boundaries of how do we use different models to do the surveillance right. And so wastewater disease surveillance for health, greater health equity is, we know that the COVID pandemic highlighted wastewater-based epidemiology as a valuable population-level approach to monitor viral pathogens. WBE has been used before to monitor drug use in communities, so this is not a new technology. But when COVID came, it became really something that was really useful, because it could be used as an early warning alert. It can complement other tools that are already existing, to aid in many things, right? One thing is, one of the biggest challenges with the pandemic is that our hospitals were overrun, right? And so if you were looking at wastewater surveillance, could you tell, 2 weeks before what your situation was going to be like when you had a peak? The nice thing with wastewater surveillance and that it does lead, before cases show up. So you get 2 weeks of information to say something bad's coming. And that should be useful for something, for preparing. So it really presents an novel opportunity for both estimating the prevalence, the incidence of COVID. We're working with some people from the School of Medicine to do projections on hospitalizations. And as I said, most of us are kind of a little bit ready to go to stop talking and thinking about COVID, but flu is a huge thing. RSV is a huge thing. And so can we just use this technology and the modeling that they're using to monitor things that are there and that always are going to be there? And I think COVID is always going to be there, right, in some way. And so I won't talk too much about this, but really the wastewater-based epidemiology really takes in information within a city. Sometimes some cities may have different locations where you can sample the wastewater, and through RNA, you can get a sense of what's circulating in the wastewater. These are some examples of the work that they have been leading on doing wastewater technology and modeling. And I think one that really brings my attention, especially because of this conference, is one of our colleagues, Colleen Newton, recently wrote a paper about the need of an environmental justice approach for wastewater-based epidemiology for rural and disadvantaged communities. Because no surprise, if you look at this slide, or this one, you can see in California, where are the regions that are doing wastewater monitoring, and where are the regions that we have the people that were mostly impacted during the pandemic, which were the Central Valley. So if you had to, give me sort of a bunch of money, I would say, let's go monitor all these people in the Central Valley, right? That were devastated through the pandemic, but somehow we're still, talking about like surveillance with wastewater as a great thing that only certain people can have. So I know you probably get it, like, I know she's really into that. But anyway, so what did we learn from this? That there are implications for technological advance, that we can use mathematics and statistical models to improve how we do surveillance. they have developed dashboards that, every county should be able to have access to their own, right? If you go and say to somebody right now, hey, please, start collecting wastewater, they're like, how am I going to use it? How am I going to make decisions? How am I going to, right? So now we want to say, this is how you're going to make decisions, and this is how you can implement, information that comes real time. I talk about also like implications for generation of actionable data. This is particular something that we are talking every day, because we have wastewater, we come up with thresholds for, mild, moderate, severe. And what does that mean? Does that mean that I have to test my whole community? Does that mean that I have to test this building? Does that mean, right? So I think we have a lot of work to do for that, but it does provide opportunities for technology advancement. And so these are just my concluding remarks. Implications for technological advance, in my mind, seem reasonable to think about surveillance systems, dashboards, and data transparency, which has been one of the major challenges. The work that we presented today was done in a way with whatever data we can gather. And the data that we always needed, we never had it. So I think that, we talk about AI and all this amazing, generation of a ton of data, but it's like the data that we needed for the populations that we needed, it's not there. So what does that mean? We're doing work on Twitter to try to understand people's sentiments, mental health problems. You look at the communities that we're trying to serve, they're not on Twitter. There's no data being generated in those places. So I do think that one good, hopeful thing that I have learned in the last 2 or 3 years is that, as Luis was saying, all of the work that they were able to do in terms of improving testing and vaccination is because you realize that you need to communicate with the communities that you're trying to support. And so I have become a major advocate for community-based participatory research. I'm not an expert, but I believe that that is the way you communicate and that you can really move the needle forward. So I think I say that social and environmental justice is especially important to address exposures that could produce long-lasting adverse impacts on health outcomes that negatively impact the future of generations of underserved communities. So I think a lot of these communities, get exposed to, COVID, and now are dealing with long COVID. With some of the work that I do with Rebecca Schmidt is for pregnant women, they get exposed to wildfire exposure. If they get exposed while they're pregnant, it will impact their kids' lives forever. So what are we doing to change that? Nothing, I guess, maybe. People are doing work, but there's more to be done. So I'd just like to acknowledge Campus for funding me, when I came here, and I feel like they have really allowed me to have protected time to go and connect with people and make meaningful, collaborations. So I'm really thankful for Mariel and all my collaborators, Healthy Davis Together, because they funded our 3 postdocs. And if you have any questions, you can email me or you can ask me now.
Okay, great presentation. Do you have any questions for Miriam or comments? Well, I bet, this is what campus is all about, right? Inclusive excellence. Outstanding scientists and outstanding community, interest and caring for our communities. I cannot imagine any other faculty in this whole campus who have the perspective that Miriam has. So I will also I think that was amazing. And so do you mind maybe to start? Do you mind commenting more San Joaquin Valley, right? Is it on doorstep? Do you think this is work that you are doing is impacting local or regional policymakers to implement some of the needs that you are highlighting? I know you are well connected with Sergio. So are people taking note of these findings to start implementing some of these measurements that we would like to see?
I think the biggest challenge right now is that the priorities of the people that lead public health, they're evolving. Like right now, people are thinking about what is the next thing. And I'm thinking, hold on, let's learn what we just learned and implement it before, another pandemic comes, which probably will be flu, because 1918 was the last one we had. So I think, unfortunately, with government, they're always like, are moving, like, what is my bottom line today? What's my bottom line? And a lot of the times, these kind of equity, issues are not really their priorities. So, I know that we will continue to push. I know the work that we're doing with Heather and Colleen is they're sold. They know this is critical. So then we have to stick with them to together be pushing. So like we had a meeting last week with a lot of public health officials, like, oh my gosh, this is like what the real big people like meet with those people, right? So they are already having those conversations. And I think that what I tell my team, that we as math and statisticians, we can't afford to just be stuck in like more models. Like, how do we like give them to them in a way that is like easy? Like all you gotta do is click this button, import your data, look at what you have. Like we have to make it. And I think that we're becoming kind of successful in that way because we're helping build transparency. Like for the Move It Up project, we put together a dashboard for the California Department of Public Health, and they can't stop talking about how amazing it is because like they're giving us money and they can see where the money is going. Like 30 vaccines right there, 20 right there. Where are the locations? So I think you have to improve transparency so that they can see these people, are helping us. I know we met with some Mixteco group the other day, and I was talking to the guy for some, collaboration, and I was like, where are the other Mixteco communities in the U.S.? He's like, I wish I knew. And he's like, I think there's some in Washington, some in here. And I was like, we can help you find those people with ArcGIS. He's like, are you serious? That would be like my goal. I was like, technology, you have a need. And I said, you don't even have to collaborate with us. You don't have to pay us. We just want to apply our work to something that is relevant and not just for the, proof theorem, which I love too, but.
Okay, so towards the end, you spoke a little bit about the challenge of missing data that well, at least coming from the big data perspective, nobody ever measures all of the things you want to know. And in many cases, very few of the things you actually want to have as sort of the raw inputs or into your model are very rarely measured and also not measured accurately. And I was curious, it seemed like a thread that was running through some of your presentation was that you could, I'm going to phrase this badly, but I'm curious about what you think. The role of modeling and sort of filling in or validating the parameter ranges for missing data, which is to say, like we can see some of the outputs, we can see some of the inputs. What can we fill in the middle with modeling to connect the dots and maybe impute or infer or whatever statistical term you want to use, so some of what that missing data is. And I'm sort of curious, do I have that right? Is that something you've been doing, and does that, how well does that work? I'm just curious.
Yeah, I think that we recognize that there is not one set of data that is going to give you the entire picture, because we know that the set of data that we have is only so representative. So like one perfect example is some work that Yuri is doing on understanding the impact of wildfire, mental health impacts of wildfire. And so, we have very tremendous wildfire exposure data on PM 2.5. But to understand mental health impacts, like how do you get that, right? So I know Irva and her team have been doing surveys on asking people. In parallel, we're trying to look at California Health Interview Survey because they talk about mental health concerns. But when you start looking at the California Health Interview Survey, and you want to see like, Stanislaus or, San Joaquin Valley, then there's so little data there that they can't share it with you because of ethics and protection, which I think that is wonderful. Somebody's got to be thinking about that. But then what does that do for me to try to understand that so that I can come? So I think what she's doing now is like, okay, let's look at Twitter during those periods where there's wildfire exposure and see what people are sharing. Let's look at the CHIS data. Let's look at this data and put it together, and hopefully, right? But another way that we have been learning is that you can actually do interventions with Twitter, where you might say, go to a specific community talk with the community partners and say, let's start a conversation and let's listen in, right? As an intervention to really like hype in, you know, and so if it's Twitter or WhatsApp or Facebook or Instagram or whatever the new thing is, then you have to think about who is using it. The young people, what about the 65 plus? They're probably not connected. So I think that we know that one data is not going to give it all to you. So I think we're trying to like leverage this piece and that piece and that piece. But one complaint that I will have is that those people like in the state that have the data at the level that they have it, they should be using it for internal, you know, knowledge, right? When they say open because 75% are vaccinated, I'm like, you're not looking at the data that we're looking at? Like, of course you have to be looking at it. Like, why as a stranger that I don't work for the department, why am I looking at that and saying, well, hold on, you know? And I think, you know, it makes me a little disappointed that maybe people that have the data at the level that they have it, they're not using it to guide their decision making. And I don't want to be mean about that because I know everybody's trying to do the best, but I think we could do better.
So, can I follow up or should I? Okay, so just briefly, I loved your point about the community-based participatory research as a sort of, I'm going to misphrase it, but as sort of as a way of gathering data and also highlighting sort of push polling is what you go and you talk to the people and then suddenly they're more aware of what's going on. As soon as you have dashboards though, I start to worry a little bit about misuse of the dashboards, because as soon as you reveal it's not just the individual identifiable things, but you can sort of, what comes out of the dashboards can be, what's the polite word? Maliciously misused by people with agendas. And I'm curious if you have any thoughts on how to mitigate misuse of data revealed via these dashboards.
Yeah, I mean, I think the dashboards that we have built have been for internal use. So, you know, when we're working with CDPH on Move It Up vaccination, you know, we thought it was important for them to know, and we're not really like sharing like, you know, 10 people in this zip code got vaccinated and they're Latino and 2 are Black. We're not saying that. We're kind of like providing big picture. But I do think that, you know, I think in terms of like the wastewater dashboards that Mari and them, you know, are developing, they're really, are kind of already there, but we're just not like sharing it with the people that they should maybe want to know about, right? So I do think that you have to be very careful because, you know, you can use it, you know, in different ways. But I think my biggest thing is independently of, you know, maybe it might not be a dashboard, but, you know, knowledge that you can go share with community partners about, hey, do you know that when there's a wildfire, you should probably be using a mask? Or, you know, right? Maybe there's very cheap filters that you can use to do that, you know, $30 filters that you can develop to clean up the air in your home. So I feel it's more like simple information than dashboards, because I think people don't want to see dashboards. I mean, there's way too many of them, and there's no need to add more. But I'm thinking more knowledge generation to empower people to make decisions for themselves. Like, it's going to rain, let me get an umbrella. Simple like that, right?
Thank you very much for the very nice lecture. I have first a little comment about missing data. So it seems to me that there's a human, let's say, leadership or maybe user problem that sometimes they don't put enough sensors in the poor communities, or they don't use the data even if they have available the data. So this is a negligence in some sense that happens, and that's terrible. We should definitely avoid that. My question is, to what extent do you feel that we have exploited the mathematical, technical, statistical methods to properly locate the sensors of the wastewater? I ask you this because I feel that maybe, you know, if there's only $1 million for all the sensors in California, we should really do this the most efficient way. Maybe you can comment a little bit of what has been done on the best methodological ways to do this.
So Maria Luisa is putting together a K99 that is going to have a name around that, because, you know, we, as I said, as, you know, people that give me your data and we'll do that cool stuff with the models, we were like, why wouldn't everybody have a wastewater? And then we learn about the cost and we're like, oh gosh, maybe we shouldn't be saying that because we're totally like not realizing it's so expensive. I was like, wow, what the heck? You know, it's like really expensive. So, so now we like take our step back. And so I think one of the questions that, you know, Mari and Chris are looking at is how do we optimally find where is the minimum number of places where wastewater surveillance should be taking place? Because guess what? If you look at Davis, we have multiple locations, but do we need all multiple? Everybody gets tested here. So we almost don't even need wastewater because, you know, right? But I mean, in the future, why not everybody's getting tested? And it really kind of speaks to some of the work that these guys did because, you know, now that there's no testing, what do you do with wastewater? Medium, high, low, right? Before, when there was testing, we're like, okay, this is the positivity rate, this is the incidence, and we can feel more confident about the wastewater. But we're really like, Davis was the only place in the US that had testing to the degree that we had it. And what does that mean for the rest of the people, right? So I do think that that is one of the things that she's doing. Like, first, how do you aggregate within a county to come up with county level estimates because hospitalizations are only at the county level? And then how do you optimally find where do we need? I don't think we need, you know, I don't think we need surveillance everywhere in the Central Valley, but where, you know, where ideally would you need it? And I feel like that might be an easier pill to swallow for people to say, hey, we're not just going crazy and asking everybody. We optimally decided where do we have blind spots. And I feel like that might be a better way. The politicians may be like, okay, that sounds reasonable. She's not asking me for hundreds, but like 10. Right? And then how are we going to use that? Because other things that we were saying is if you have a surveillance here and nothing around, you know, there's nothing to borrow from around, right? And so I think there's a lot of borrow information, like spatial temporal models they're going to start implementing. But there's nothing done on this. We're collecting data, and I do kind of feel for politicians where like we're spending all this money for surveillance, and how are we using it? So far, to just not know what we, you know. So I think hopefully we can say that we have value to them, and they can say, okay, come over here, and you know, we'll give you money to hire another postdoc, so that we can do good stuff. So thank you so much.
Yeah, thank you, Miriam, for a wonderful talk. I have it's more of a rhetorical question, and maybe you can answer, and if other people want to pitch in, that's also good, because today is really about, we, as I said earlier, we built in a lot of time for discussion so we can talk to each other and brainstorm about these issues. So the question is, why are equity issues not a priority to government? And especially in California, given that, for example, the farm workers move the economy. So even if politicians are only thinking about the dollar sign, well, the minoritized communities are fundamental to the economy in California. So why are equity issues not a priority?
One thing that I've learned in some of the presentations that I've given that I didn't recognize is farm workers fit California, but they can't fit themselves. Or they can't eat the foods that they create, right? And I'm like, how does that even make sense, right? I've also seen a documentary where, you know, people from Mexico, because I'm from Mexico, we come here, American dream, you know, in the US, you can get this and that. You come here, and people in the Central Valley don't have water. In Mexico, you were poor, but you have water. And I'm like, how do you come to a land of opportunity and you can't have water to shower yourself or even drink it? I mean, it's just like, to me, it's incomprehensible, and I feel like a lot of my work, and I was saying to you that I was putting together this slide about like self-discovery. It's like, why am I excited about these things, right? Because I was an immigrant, you know, I came here illegally, and my parents worked this hard, and so I feel like I know what that is, you know, and so I feel like I'm now in a position to understand those things. Even if I don't want to, they're like part of who I am, right? And I'm just, you know, I get very excited about this. I mean, I don't know why that is. You know, why this is forever, right? Centuries of how, like, you know, I don't know. I mean, to me, it's, yeah.
Can chime in there, actually. Maybe we all can chime in. But, you know, I think at least the COVID-19 pandemic, there is all, I am a half full glass person, and there is a silver lining of the pandemic, which actually show all Americans that are communities of color out there that are experiencing disparities. We have been working in disparities for 10, 15 years, but disparities was never part of the national conversation. Equity wasn't part of the national conversation, right? Same with the horrible actions that happen, things that have been happening to black men in the country. These things are showing all Americans that there are people out there who are suffering unjustly. So I know equity, like, oh, why didn't think about equity before? Because we don't have all these horrible, events with people in the black community. We don't have a pandemic that mortally affected communities of colors and marginalized communities. So, at least my comment to this is the silver lining on equity. In the silver lining on the pandemic and on the events that are happening in the last 2 or 3 years is that this is part of the national conversation, and it's our responsibility as faculty and community to be loud and to advocate for this, because I think finally a lot for politicians and policymakers are also taking note, right? And also as a society, I think hopefully we'll get better as we recover from this.
I guess I will add one thing that, I feel like so I'm married to my husband is from Montana, right? And, he's a basic scientist, and we met, and, he was in MIT, I was in Harvard, I'm going back to California. So anyway, we got married. But, having these conversations with him, I realized he's an amazing person, respectful in all the good qualities in a human being, but there is no bone in his body that allows him to understand these things because of his experiences. And so when we have these conversations, it's always and I have to give him examples. Remember that time when we went to buy a car and it was my car, and the guy said, you sign here because I'm not the owner. And I'm like, it was my car. Why did you have to be the one, It's all these experiences where somehow they assume that he's the person and I'm the one that take care of the kids. Because sometimes people may think, I'm the caregiver for my kids. And I'm the nanny or something, as opposed to the wife of that wife do it, Anyway, there's a lot of experiences, and I have to tell him, did you notice that he wasn't even looking at me? I'm not even there. And he's like, oh, you're right. So I feel a lot of it is not bad intentioned. It's just lack of awareness. So I can tell you now, how many years we've been married, that he realizes those nuances. But before he didn't. So I feel like a lot of people, maybe, the way we are brought is how we see the world. And I only see my world in so many different, I wish it was nice and straight and all that. But so I do feel that because I think just increasing awareness, and then maybe the time is right now, and it wasn't before, as you said, those examples that we've seen that are on our face that we can turn around. But I also don't want to be that person that you're having dinner with, that this is all she talks about, because, I don't want to be please stop it kind of about, So, but I do, love the idea that at least having conversations, it's a very good start.
I wanted to bring sort of the glass half empty side to that, because last summer there was a published paper where they had interviewed, and all the white Americans seemed to care less about COVID once it was found that minorities were suffering more from it, right? So it's something exactly the opposite of what you would hope for. People cared less about it once they realized, oh, we're less affected than all these other groups. Yeah. So that was sort of literally kind of the opposite, right? Very disappointing that it was exactly the opposite of what we were hoping for.
Thank you. Do we have any other comments or questions? I think it's now 10:30, so we're meant to go for a break. So let's give our last round of applause to Miriam. Amazing presentation. Thank you. We will be back here at 11 a.m., so half an hour. Also help us clean the place, because I don't know if we will have someone to clean at the end, so please help us take care of the room. Thank you.
There's coffee outside.
So there's, if you go out that side of the building, all the way to that end, and turn right, you'll see some poster boards. If you follow them around, you'll find a bunch of really amazing food